So we'll get started. So I'm Francis Lowe. I'm one of the chief residents, and for the our clinico-pathologic conference. So we do this once a week throughout the entire year, and where we invite an expert clinician to give their thoughts on a clinical case. And the purpose of this is not so much about the diagnosis, it's about clinical reasoning and how they reason through a difficult case. So this is a case of a 52-year-old female with a history of hypertension, diabetes, CKD, complicated by nephrotic range proteinuria, who's presenting with jaundice. And our expert clinician today is Dr. Jaquelyn Fleckenstein. About Dr. Fleckenstein, she's a professor of medicine here and director of the hepatology program. And then her undergraduate was Cornell. She was here. She went to St. Louis University for medical school, University of Michigan for residency, and then Johns Hopkins for her fellowships.
Is this a primary liver disease that just also has a renal complication? And we know that 20 to 25% of people who have chronic liver disease are also going to have kidney disease. So that would be the most common. I mean, certainly when you hear diabetes and jaundice in the same system, you're going to start, my first thought is, oh, this patient has metabolic syndrome, they have MASH, and then they have kidney disease from that. But I've done this a few times, and the chief residents never make it that easy. So I'm pretty sure that's not the case here. But then the next thought is this, is this just a systemic disease that's hitting both the liver and the kidney? And so that is also very common to happen. It's less common to have a primary kidney disease with a liver complication, but that can happen. But most likely, I think it's going to be one of the first two. So when I start thinking about a primary liver disease complicated by kidney disease, well, then there's definite categories you should think about. Certainly viral hepatitis. You guys, now that we can cure hepatitis C, you're not seeing it very often, but we used to see hepatitis C-associated cryoglobulinemia and renal disease all the time. Thankfully, we are now curing hep C, and we rarely see that. We still see it with hepatitis B, and there can be several kidney diseases associated with hepatitis B. And then sometimes this is just from obstructive jaundice. Now, obstructive jaundice isn't going to cause proteinuria, nephrotic range proteinuria, but it certainly can cause acute kidney injury and bile cast nephropathy. In PBC, we think about renal tubular acidosis, interstitial nephritis, Wilson's disease, one of the classic hallmarks. It's on every board exam. I just saw our fellow come in. This will be on the boards next year. They'll give you a renal tubular acidosis, and that's your clue for Wilson's disease. And then what most people don't realize, because it's very, very rare, but it does happen, I've seen it, is that you can get nephrotic syndrome with alpha-1 antitrypsin disease. So, but then there's even more systemic diseases that affect both the liver and the kidney. So obviously, I don't think this woman is pregnant at the age of 52, but we certainly see these diseases in pregnant women. I think we probably would have known if she had polycystic liver or kidney disease, so that's unlikely. But this woman could have sarcoidosis. Certainly that can cause both kidney and liver issues. Amyloid, which is a classic CPC diagnosis, certainly could lead to nephrotic syndrome and jaundice. Sickle cell disease is also very common. PNH, we had one just a few months ago, a new diagnosis of PNH with Budd-Chiari syndrome. There's a whole spectrum of autoimmune vasculitic diseases that can present with both. I don't want to forget heart failure, and then the metabolic syndrome, as we talked about. So this is not comprehensive, but a general review. So then, I also always like to have a different category looking at drugs, because that is just so common. So many medications I've got listed here can affect both liver and kidney. And these are often ones we don't think about. But ACE inhibitors have been well described to cause cholestasis. And here we have a woman with diabetes and nephrotic syndrome. Very well could be on an ACE inhibitor. And then infections. If I started describing this case to my husband, the ID doctor, the first thing he's going to say is, of course, an infection caused this. because he thinks infections cause everything. But there's quite a list of infections here that patients do get that could be contributing. And then just the last couple of slides on my thoughts is, okay, maybe, is this more of a complication of her kidney disease? So, nephrotic range proteinuria is not benign in the sense that you increase risk for thromboembolism. So could this patient have clotted or hepatic veins because of the nephrotic syndrome? Or the nephrotic syndrome puts you at higher risk for infection. So does this woman have underlying liver disease and is jaundice because she's infected? Those are things we need to think about. And then not to delve too much into the kidney world, but if, figuring out whether this is a primary glomerular disease or more of what we call an overflow proteinuria may also help, because certainly amyloid, as I talked about, is going to be high in the differential. This also brings down, is this a problem with jaundice, not because of conjugated hyperbilirubinemia, but unconjugated hyperbilirubinemia, such as the patient had hemolysis. So on my final slides, we'll talk about, you have to think about the classification of jaundice. So the first thing you want to find out is this unconjugated or conjugated hyperbilirubinemia, and that should be your first thought when you're presented with somebody with jaundice. So this patient, we don't know she has underlying liver disease. She could just have unconjugated hyperbilirubinemia from hemolysis or increased bilirubin production. She could also simply have Joubert syndrome from impaired conjugation. She could have impaired uptake because of heart failure. More than likely, though, there's more common causes of conjugated hyperbilirubinemia. And the first thing you want to distinguish in that case, is it intrahepatic or extrahepatic? And so extrahepatic is what we think about when the bile ducts are blocked. There's a long, extensive differential diagnosis for that. Stones being the most common. And in intrahepatic cholestasis, that's what we think about with most of our intrinsic liver disease. This is going to be our patients with PBC, with cirrhosis, viral hepatitis, sickle cell disease, infiltrative diseases, medications. Very rarely, it's more of a problem of the canalicular organic anion transport or sinusoidal uptake, but those are very rare and usually diagnosed much younger in life. So I think that was my final slide, as sort of my general.
Thank you so much for the initial evaluation for this, and kind of keeping it broad to start, and then thinking about that liver kidney axis. View the HPI here. So we have 3 weeks prior, she had an elevated blood pressure up to the 190s that led to some medication adjustments. She felt subsequently fatigued, lightheaded, and run down as though she had the flu, some dizziness, some nausea, and she symptomatically improved by holding her medications. 1 week of lighter stool, 3 days of increased weakness and fatigue. She had seen her cardiologist at the time that had done those medication adjustments. And then outpatient labs found elevated creatinine, and so she was, or beyond her baseline. And so she was sent to the emergency department for IV fluids. She was then admitted because of, she was found to be jaundiced and also have elevated transaminases. And then this was at the outside hospital. After 3 days, she was feeling symptomatically well and mentally sharp with improvement in her AKI, but still jaundiced and still with elevated LFTs. So they transferred her to Barnes for a liver specialist evaluation. On review of systems, she had a poor appetite. She's had chronic lower extremity swelling over about the past year, for which she's followed with nephrology. No abdominal pain, no fever, no nausea, vomiting, or diarrhea. Sorry, I think that's a little bit contradictory. She was intermittently nauseous versus not.
Okay.
We'll give you a little bit more details here. So for history, as you already know, she said maybe someone told me I had a fatty liver at some point. She's had a cholecystectomy, no family history of particular diseases that would point us in one direction or another. She was on a number of blood pressure medications, namely amlodipine, hydralazine, lisinopril, and hydrochlorothiazide, Lasix, as well as metoprolol. She's on insulin, as well as some other medications for metabolic disease. No allergies, and otherwise, social history is negative for supplements, herbs, mushrooms, and alcohol. So given that, what are some of your initial thoughts here?
Yeah, so Well, going back to her history, when she presented with the feeling run down as she had the flu, dizzy, nauseated, presumably volume depleted enough that she was sent to the ED for fluids. One of the first things you think about is when you have AKI and those symptoms is some degree of ischemic hepatopathy. I don't know how hypotensive she was, but certainly I would be concerned about that. I think it's pretty profound if she had to go to, it wasn't just holding her med, she had to go to the ED for IV fluids. So that's one thought. And it's very common, in the setting of ischemic hepatopathy, you have an acute rise in the liver chemistries, an acute drop after you fix the hypotension, and then it's the bilirubin that stays elevated for a much longer period. So I don't know, it's kind of vague when it just says elevated LFTs, but still jaundice. Perhaps they just didn't wait long enough to see resolution of that if it was ischemic hepatopathy. But she also had a week of lighter stool, which tells me she was pretty jaundiced before this started. I wouldn't expect her to have light stools if she wasn't jaundiced. It makes me wonder if there's more going on as the primary problem caused these symptoms, not as the result. So this could be a diagnosis for any hepatitis, infectious, autoimmune, any drug-induced, just these sort of vague, non-specific symptoms and elevated liver chemistries. So, I mean, she's at risk for viral hepatitis. Hepatitis A runs below the level of epidemic at all times. I mean, there's a whole range of things this could be. It sort of depends on the pattern of the liver chemistries now. She is on multiple medications that have been associated with drug-induced liver injury. I don't know which one of these are new. I would not expect a atorvastatin to do this, even though everybody worries about statins and liver disease. But this sounds much more significant than that.
How does the time course for different medication-induced drug injuries impact things? This happens,
right.
not infrequently.
Yeah, usually it's we think about it as more recently started drugs within 6 months. There are a few drugs that can take longer. Somebody on long-term nitrofurantoin, minocycline, sometimes that's a longer course before they get their associated drug-induced liver injury. Some of them are even longer than that. Amiodarone, methotrexate, sometimes it's more of a cumulative dose, but in general, we think that under 6 months.
Right. Moving on to our exam then, not really too much new. She's stable at this point by the time she gets to Barnes, and then confirmed with scleral icterus. She does not have elevated JVD, at least per documentation. And then otherwise, her abdomen was soft, non-tender, non-distended. No one had palpated any organomegaly, but I will tell you that there was some splenomegaly on the imaging. She was jaundiced, and she is presently ANO times 4.
Okay. And I assume the blood pressure of 150/60 is after she's been volume resuscitated.
Now that she's been volume resuscitated.
Okay. All right. Well, she appears jaundiced, so.
And here's the kind of money slide for kind of shedding some thoughts on how you're interpreting this in light of kind of the background liver and kidney history, and then kind of risk stratifying here.
Right. Well, I mean, the first thing we notice is that this is primarily a conjugated hyperbilirubinemia. This is not, I would not be thinking down the pathway of increased bilirubin production, as we talked about in the slide for the differential diagnosis of jaundice. I don't know, the albumin is difficult to interpret in the setting of someone who has nephrotic range proteinuria, but she has a very significant sort of mixed pattern liver chemistry elevation, and all of them are elevated significantly. She appears to have maintained hepatic function with an INR of 1.4. So, there's just a broad range of differential diagnosis for this acute hepatitis still.
Sometimes we've heard about the level of elevation of the LFTs. Does that play? How much does that play into a role? Are we thinking like just orders of magnitude, or? Yeah,
no, it definitely plays in a role. There's not that many liver diseases that will get your AST and ALT greater than 1,000. So this is not the patient who has acute alcoholic hepatitis. We usually see that under 500. When we think about, there's still a broad differential when the liver chemistries are above 1,000, AST and ALT are in the 1,000 range, and that would be ischemic damage. I don't know what the pattern, how quickly these went up and where they were, but certainly ischemic, autoimmune injury, viral hepatitis can do this. And then sometimes we see it with any toxic hepatitis. And then sometimes even with ascending cholangitis, we talk about sort of a backwash hepatitis. So sometimes with acute choledocholithiasis and cholangitis, which I can't say she doesn't have with an alk phos of 1,000, but you can see this.
And then do you mind just talking a little bit about cholestatic versus hepatocellular injury, as well as the role that an R value might play?
Yes, well, yeah, that's a point. I rarely calculate an R value. That seems to be something of the younger generation. I look more at the pattern of it. But in general, if you have a more primarily cholestatic pattern, you're going to expect to see the alk phos higher than the AST and ALT. If it's the primarily hepatocellular, you're going to see a lower level of the alkaline phosphatase. This is sort of a mixed pattern. Okay, normal diff. So this woman has thrombocytopenia. That could be, and mild anemia. That could be, this could be of significance in the setting that she has splenomegaly, that there's more chronic liver disease going on, or at least something that's led to some degree of portal hypertension and splenomegaly. Okay. Alternatively, you could, throw something at me like she has a primary lymphoma with splenomegaly and, a secondary cause. But this is more smelling like there's chronic liver disease.
Okay. So given this, since we do admit a fair number of liver patients, what are some of those initial diagnostics, and how do you do you group them, or what's the?
Yeah, well, one of the first things I'd like to see is some imaging. So, I mean, I think it's very hard for anybody to get admitted here and not at least get an ultrasound, but I would certainly want to get I would start with an ultrasound, particularly in the setting of her chronic kidney disease. And I wouldn't want to give her a dye load, but I think an ultrasound could be very helpful. We'll be looking for ductal dilatation, which it doesn't have to be dilated in the setting of acute obstruction, but it might be very helpful if we saw it. I would like to see if her liver looks architecturally abnormal. Is there nodularity? And want to know whether her portal vein is thrombosed. Because as we said, nephrotic range proteinuria puts you at increased risk for portal vein thrombosis or any hypercoagulable state. And then I would like to see if she has truly how much splenomegaly she has. So that would be my first diagnostic.
Sure. Well, I'll skip the labs here. Okay. We'll give you some imaging here. So she had given her kidney disease, they had not gotten it with contrast. She has her known cholecystectomy, splenomegaly at least greater than 12 centimeters. And then otherwise just some marginal renal calculi. She had a right upper quadrant ultrasound and didn't find any evidence of portal vein thrombosis. They did call some hepatic steatosis. And otherwise she'd gotten an MRI of her abdomen and this called no ductal dilatation. Okay. As well as a 4 millimeter common bile duct. Right. And firm splenomegaly. Her
liver does not appear, I mean, there's a little variability up superiorly, but it doesn't look frankly cirrhotic. The steatosis we would expect given her diabetes and this history of fatty liver disease. So, I think that this would right away steer me away from thinking that she has, extrahepatic cause of her jaundice. And I would be more focusing on the intrahepatic causes. She has evidence of portal hypertension with her splenomegaly, the trace ascites, the pleural effusions. I don't know how chronic that is. I would have to assume it may be more chronic. Okay. And you don't have to have cirrhosis to have portal hypertension. You can have cirrhosis without it being noticeable on imaging, but you can also have non-cirrhotic causes of portal hypertension.
Okay.
Okay.
So we'll pull into some labs here.
Yes, I would definitely want some more labs.
All right. So her transaminases, we had those initial numbers, and then they basically were steadily decreasing over the course of her admission. She had unremarkable toxin levels, and then broadly negative infectious workup, broadly negative autoimmune workup, elevated ferritin, TSAT, as well as some low ceruloplasmin copper, and alpha-1 antitrypsin that was within normal limits, an A1C of 9.0. They did get a biopsy very quickly after arrival. And then we've got our pressures here as well. Otherwise, an elevated GGT, as well as they were tracking filtered bilirubin in the urine. and then also otherwise got a urine protein creatinine that confirmed that there was nephrotic range proteinuria.
Okay.
So given this, kind of how does this shift?
Right. Well, there's a lot of labs here to go through. So the transaminase is steadily decreasing, makes me think that there was some acute insult, and now it's getting better. What that insult is, I'm still not sure, but it does look like that's, the ongoing, that's the case. So less likely, if they're just steadily decreasing, it's less likely to be, acute hepatitis C. Hepatitis B could do this, but I just don't know how quickly they're improving. This is less likely to be an autoimmune disease. If we haven't started steroids, I wouldn't expect to see a sudden improvement. I don't know what medications were stopped, whether that was contributing or not, but it's encouraging. Having her bilirubin stay up is not a prognostic sign that she's going to have worse liver damage. I noticed the CPK being mildly elevated. I don't know what it was before, but certainly that would lend some credence that maybe this was an ischemic hepatopathy, because also she has an elevated CPK. There doesn't appear to be any evidence of infectious hepatitis, at least the common ones. There's others that haven't been checked for that. You didn't give me any history to make me think that she suddenly gotten syphilis or, leptospirosis or something else. I assume the EBV positive is for prior infection. Okay. So it's, any woman of middle age certainly is increased risk for an associated autoimmune hepatitis. Is at a higher risk with diabetes, possibly, but these are very reassuring autoimmune studies. Normal IgG, the negative smooth muscle antibody, all of those are reassuring. The ferritin of 2100 is not just signifies acute hepatic inflammation. It would not make me think that there is hereditary hemochromatosis. That never causes an acute liver injury. It's chronic. So when you see something like this, particularly in the setting of a normal T saturation, this is just hepatic inflammation. Ceruloplasmin, she's old to be certainly presenting with acute Wilson's disease. Usually that's diagnosed in younger years. It's not unheard of for it to be Wilson's disease, but ceruloplasmin is made in the liver. So this could just be the low ceruloplasmin could just be the result of a period of hepatic dysfunction. The serum copper being low at 21 just reflects the ceruloplasmin being low. And so I didn't calculate it in my head, but you'd really want to look at the non-ceruloplasmin bound copper to make a decision that she was copper deficient, because the serum copper is ceruloplasmin bound plus non-ceruloplasmin bound. So it's going to be low just by the fact that the ceruloplasmin level is low. So you don't want to be fooled by that. Reassuring alpha-1 antitrypsin level. That doesn't mean she's not a heterozygote, but that shouldn't lead to nephrotic range proteinuria in this presentation. So not surprisingly, with somebody who's got nephrotic range proteinuria, presumably from her diabetes, she has poorly controlled diabetes with a hemoglobin A1C of 9. Now, the transjugular liver biopsy is interesting because one of the things you would worry about too is in the setting of ischemic hepatopathy, was there already underlying congestive hepatopathy in a diabetic woman who very well could have heart disease, but it's a reassuring normal right atrial and free hepatic pressures. So that would make me think less that we have congestive hepatopathy. Her portal systemic gradient is fairly normal at 6. Now, here we have a woman that has, I'm saying, could have portal hypertension, splenomegaly, thrombocytopenia, trace ascites, pleural effusions, but has a normal portosystemic gradient. So how does that happen? Well, you can have pre-sinusoidal causes of portal hypertension, and those are not picked up on a transjugular liver biopsy. So that, unless there's another reason for the splenomegaly and things, I would have to think that perhaps she has a pre-sinusoidal cause. GGT being up doesn't tell me much. She's got bilirubin in the urine, which goes along with the fact that she's not an obstructive hepatopathy.
Okay. So we will get our pathology results in just a moment. So you had mentioned a couple possible kind of directions to head to. I guess a little bit more information. So she did stop many of her blood pressure medications when she was inpatient. They continued her on her insulin. They stopped, the allopurinol, the statin, and as well as the semaglutide.
And were any of those new?
So she had been on the hydralazine and lisinopril hydrochlorothiazide starting in December. And then they had been adjusted. And sorry, this is so this would be 3 to 4 months prior to showing up. And then she had her metoprolol, Coreg changed to metoprolol at that most recent visit. I think the amlodipine was started at that visit.
Okay, so lisinopril and allopurinol were the most common. Okay, and then what was that's very helpful. Allopurinol is associated with granulomatous liver disease. Not so much it could present with this acute hepatitic picture. Certainly the lisinopril, as we already talked about, can cause cholestatic hepatitis. But what about her history? I mean, had she traveled anywhere, done anything, had any unusual exposures?
No unusual exposures, no unusual supplements or anything like that. Really, I think it was kind of presenting more as that kind of cardiology kind of focus.
And do we know what her echo shows? Do we know more about her heart function?
I think there was some degree of like right-sided dysfunction, but that was it. It wasn't the kind of primary part of the case. Okay.
And are you how high did her liver chemistries get when she first presented?
It was at the 1400. This is the worst that they got.
Oh, that was the worst that
they got. And then basically day over day, they went down by 100.
Okay.
Yeah. And then I guess to complicate the course, so I mentioned that her creatinine had gotten a little bit worse. I'm going to give the hospital update a little bit later. But basically her baseline is 1.7. Right. She presented to the outside hospital at 3.2. She got her fluids, was 2.4. And then while she was on the floor here, although her enzymes got better with the holding of the medications and just general management, she all of a sudden had a altered mental status event. The hospitals had come in, she was ANO times 0. And then ultimately they held her on the floor for just a bit and then went up to the ICU and then kind of improved mentally back in the ICU for a little bit. And then at that point, they started considering for transplant evaluation.
Okay. But which is a little bit unusual unless you're telling me that her INR went up.
It went up a little bit.
Okay.
I mean, it was like 1.6, 1.7, 1.8.
Okay. Other thing that on physical, we talked a little bit about physical exam. Was there stigmata of chronic liver disease? No stigmata of chronic liver disease. Okay. Okay.
Right. So let's get our pathology results here. And we're joined by Dr. Larry Ha. Thank you very much.
Just control the computer here.
Yes.
You guys hear me loud and clear?
That one.
Oh, okay. I could just do it from here. Yeah, so normally I go into like the punchline of these things. Oh, I guess it's a quick intro. So I did my residency at UC Davis, and I'm currently doing a 1-year GI pathology fellowship here at WashU. So pleasure to be here. So yeah, this is my second time being at CPC. So just kind of before I go into the punchline, kind of go like a kind of the basics of pathology, since you probably don't have too much exposure during your guys' internal medicine rotations. So just going over like the portal triad, and that represents zone 1. And that consists of the hepatic artery, the bile duct. With the bile duct, you can have like low cuboidal cells surrounding it, and the portal vein. And so these make up the portal triad. And then surrounding, as you kind of imagine, the most of the liver is made up of hepatocytes, which can be described as like polygonal pink cells with these like really large nuclei. And on the right picture here is the flow for the liver. So it goes from zone 1, 2, and 3, kind of numerical order, from the portal triad to the sinusoids over to the central vein. And it kind of goes, and also has a pretty nice diagram here. So you kind of see like the oxygenation kind of goes a bit down as you go from zone 1 to zone 3. And then as you you're most likely going to have more entry in towards like zone 3, because you'll see a lot more hypoxia, detoxification, injury, as well as like some congestion. And since that's like kind of where the end point is. And so kind of just like little intro to pathology. I mean, there's only so much I can discuss in the short amount of time that I have here. So just kind of interpreting the subtle changes of the cells based on the biopsies or resections that we get, and try to correlate everything. And some of the things that we try to keep an eye out for, you know, for example, in this like little box, is like what kind of cells like do we like see here? So like on low power, on the left picture here, you see, you know, just mostly pink, maybe some, you know, groups of these dark purple cells. It's kind of hard to tell. You don't know exactly what they are until like you zoom in, which is part B. And just kind of a quick refresher on like the type of cells you might see on like much higher power. Like the top is those multi-lobe that you see in neutrophils. The second picture here in the middle, you can see kind of more the fried egg shape. That's more plasma cells. And then the bottom is lymphocytes. This isn't like the actual biopsy, just giving you guys like a kind of a quick, you know, introduction, just to get you guys a little more familiar. And then there's like other subtle things that we kind of keep an eye out for when we're looking at these like liver biopsies as well. So things like, you know, is there like proliferation of bile ducts? So kind of referencing back to the kind of low cuboidal cells that you might see. If there's like a bunch of them like enclosed together, and then that kind of points towards like an injury to the liver. And as with many things, like we can see a lot of things on pathology, but then how it correlates to it can mean like a lot of different things. So our reports for liver biopsies can be pretty long. So if we even see something just as simple as, you know, like a proliferation of bile ducts, it can raise a wide differential, such as, you know, biliary tract. Could this be a PBC, PSC? Could this be alcoholic, MAFL, hepatitis, etc.? Oh, okay. It's like you changed the background now. Yeah, so this is like the biopsy itself. So the kind of the far left is kind of like the normal reference range to see like what a normal liver should look like. So it's kind of like diffuse pink, and that's kind of how a liver parenchyma should look like. And it might be kind of difficult based on this picture, but you're kind of take my word for it. So like the top right is more what normal liver should look like, and then to the left of it, it's a lot paler. It's not quite as I don't know how to phrase it. It just looks a lot lighter compared to what the rest of it should look like. And it kind of raises a differential. Could this be like some sort of necrotic picture? Could this be some sort of cirrhosis? So, and there's a little bit of like lymphocytes in here as well. So just something that we kind of keep an eye out for when we're looking at these biopsies. Again, usually we start on low power. So normally we kind of see like the, you know, typical liver parenchyma, but when we zoom in, like this is the thing that caught my eye. And so we also do like additional stains when we're looking at these biopsies. So this is the trichrome stain. And so we use it to see if there's fibrosis in these liver biopsies. And the bottom right is kind of like a bit of reference where we're kind of looking for how we grade fibrosis. So mild would be if there's lots of fibrosis in the portal tract, and so it'll be like a lot of blue in that area. Moderate would be more parasinusital fibrosis. So it'll be in the portal tract and then kind of extending out towards the zone 2 area. And then severe is kind of more towards the bridging fibrosis, where the fibrosis extends from portal 1 over to, or zone 1 to zone 3. And so in this like picture here, it's you don't really see too much blue. So that means it's not much really a fibrosis going on. So and kind of just bring all like the pictures together, we kind of favor this more towards a necrotic liver parenchyma type of picture. And so it favors against like steatohepatitis. And so what we call this is submassive necrosis, and the alternate name for it is confluent necrosis. This is kind of like a picture of what some massive necrosis would look like if we had like the entire resection, because since we get a biopsy, we only see like a tiny sliver of, you know, like just a tiny needle. But if we got like the whole resection, you'll see a whole like necrosis of hepatocytes in larger areas throughout the entire liver. And these things can be seen in like severe hepatitis, autoimmune, drug, and there's usually a bit of inflammation and liver failure involved with this. And less commonly, it would be associated with acetaminophen shock and heat stroke. And I think usually if it's like drug related, we typically see this more in zone 3, but with the limited biopsy, it's kind of hard to tell. And so this is kind of just what the final results is. So features of bridging necrosis, submassive hepatic necrosis without immune-mediated inflammation. And so, yeah, we looked at through like liver tox on what might cause subhepatic necrosis, and kind of go through like all the different medications. So definitely lisinopril could definitely cause this type of injury, as well as hydralazine. Oh,
Well, given this, what are your thoughts?
Well, thank you. I didn't pay him to do that. Yeah, so we had been circling around presumably drug-induced liver injury, which would make the most sense just based on what we have. Certainly hydralazine does it. I mean, we're suspect of every drug. It's like I said, usually the ones in the first 6 months. I don't know if we could say it's hydralazine over the lisinopril. I mean, but probably not the allopurinol. There's no granulomas. So, there's no, you can't always predict you can't predict who this is going to happen to. And it's just a matter of withdrawing the drug and see how they do. I understand now why they started evaluating her for transplant, because with submassive necrosis, you can lose about 75% of your liver as long as you stop the process that killed the liver, then your liver will regenerate. So it's the same thing. You can resect up to 75%. And if you have that 25% that's healthy and can hold you through, your liver will regenerate. It's pretty amazing. So sometimes the pathologists help us out and they see how much necrosis there is, and they're like, you better start thinking about transplant. So we appreciate their help. I mean, sometimes it's just very obvious to us clinically, but I've had patients where I've really felt like they weren't doing that poorly. And then I see the biopsy and I get very scared and I say, okay, we've got to at least have you worked up for transplant.
Is there a scenario where you would do like steroids while waiting for that? Or?
You can. The drug-induced liver injury that's associated with autoimmunity, nitrofurantoin, monoxycycline, some of those patients do respond well to steroids. We oftentimes will try steroids, but when you have this much submassive necrosis, and there wasn't a lot of lymphocyte injury or plasma cells, this is not probably going to respond. It's a matter of, does the injury over and let the liver repopulate itself, or they're going to need a transplant? And the prognosis is far worse with drug-induced liver injury than, with the exception of acetaminophen, which is sort of a one and done, than some of the other things. I mean, acute hepatitis B, you may have a better prognosis than drug-induced liver injury. So what you didn't tell me, I mean, you told me she had mental status changes, but what you didn't, I would expect to see the INR rising significantly in association with the mental status changes. And then there's a whole nother category of drug-induced liver injury that's important to recognize. This one had a clearly very hepatitic picture, right? We knew there were dead hepatocytes, but there's mitochondrial dysfunction syndrome that you see with certain drugs, INR, but not a very high liver chemistry elevation. And so it's not the hepatocyte death, it's dysfunction. So
thank you very much. And here was the rest of the transplant evaluation here. But otherwise won't dwell too much on that. I'll just kind of finish up the hospital course.
Okay.
So she had a 1-month hospital stay. She got her transplant with minimal complications. She was discharged on immunosuppression and prophylaxis, and then otherwise came back a little bit later, and as a complication of her immunosuppression, had some esophageal changes as well. And otherwise, we talked a significant amount about drug-induced liver injury, and there's kind of all these, can be a laundry list of medications that folks come in on, but it's kind of how do you put all this together? Because there's 10,000 or 100,000 medications to think about. How do you even build a schematic in your head?
Yeah, we use liver tox, so I certainly endorse that for, every patient. As a hepatologist, I can't remember all these drugs. I'm using them all the time. There's new ones coming out. So have that in your armamentarium. It's very easy to use. Anyone who's rounded with me or been in clinic with me knows I use it all the time. So it's very helpful, an incredible resource. But so much of liver disease is history. So it's really the history. And I can tell you that they didn't come up with much because we wouldn't go directly necessarily to a liver biopsy. So the fact that that was done very early tells me my colleagues who saw this patient really didn't have any idea, not that they didn't have any idea, but they needed more data to prove that this was presumed drug-induced liver injury. So, there, as you put on your slide, there's the ones that we know clearly that cause liver injury, acetaminophen being the most common worldwide. there's the idiosyncratic ones that can be any drug. That's why we say any drug can do anything, and you're never going to be wrong if you list drug-induced liver injury and a differential diagnosis for acute hepatitis. You'll never be wrong. You might not be right, but you won't be wrong. And then there are some that you can, it's the pattern. So in this country, the #1 cause of drug-induced liver injury, the most common drug is Augmentin. So, I mean, it is so by far the most common. I can tell you that whenever my kids were sick and little, I never wanted them to get Augmentin because I knew too much. I would say amoxicillin was fine, but stay away from the Augmentin. And it can happen, it can be delayed. It can be weeks after you've had the Augmentin, so much so that many times the patient doesn't even remember that they took it, and I've had to call the pharmacy to find out that they had gotten Augmentin. Very common in young people. So that one you have to remember just because it's so common. And then, we have, as you put down there, the new whole classification of, the checkpoint inhibitors that can be months afterwards and take months to resolve. And, we're seeing that more and more. I think I was on service 2 weeks ago, and we probably had 5 consults in the 2 weeks just for checkpoint inhibitor hepatotoxicity. Those do respond to steroids because of the autoimmunity. And then the nice thing about liver tox is they also have a section for supplements, because I can't keep track of all of those, but that's very helpful too.
Well, thank you very much, Dr. Fleckenstein. We really appreciate your time. Nice job. I learned a lot.